Welcome to Weekly Neurology Deep Dive. This deep dive is for educational purposes only and offers a summary of recent research for neurologists. It is not a substitute for reading the full article. This week we're diving into a paper titled Neurological Complications of Immune Checkpoint Inhibitors, a Practical Guide by Carr and colleagues, published in Practical Neurology in November 2024.
Immune checkpoint inhibitors, or ICIs, are really changing the landscape of cancer treatment, but bring with them a unique set of potential neurological side effects. This deep dive will focus on equipping you to recognize, diagnose, and manage these complications in your practice.
So to start, can you give us a quick overview of how these ICIs actually work?
They essentially release the brakes on the immune system. ICIs block off switches like CTLA-4, PD-1, and LAG-3 on T cells, which allows a sustained immune response against tumor cells.
And this translates to some pretty impressive results when it comes to survival for certain cancers, right?
Exactly. Take metastatic melanoma, for example. Patients treated with combination ICI therapy have a median survival exceeding 70 months, compared to less than 6 months with traditional chemotherapy.
That's huge. I know ICIs are being used in more and more types of cancer. So how frequent are these neurological complications we're talking about?
The good news is they're relatively rare, affecting 1 to 4% of patients on monotherapy and up to 14% with combination therapy. However, the severity is a serious concern.
Meaning that even though these complications are rare, when they do occur, they can be quite serious.
Yes, these complications are often graded as 3 or higher on the CTCAE scale, indicating significant medical concern and potential for long-term disability or even death. Early recognition and management are critical.
That brings up a key point. How do we differentiate ICI neurotoxicity from other neurological issues that we often see in cancer patients?
You've hit the nail on the head. That's one of the trickiest parts of dealing with these complications. ICI-induced syndromes can look a lot like conditions we're already familiar with, like Guillain-Barré syndrome, or chronic inflammatory demyelinating polyneuropathy. But the underlying mechanisms, and therefore the treatments, are distinct.
So we can't just assume it's business as usual, even if the presentation seems familiar. Are there any specific ICI-related syndromes that we should be particularly aware of?
Absolutely. One challenging example is triple M syndrome.
Okay, triple M syndrome, that sounds serious. What is it exactly?
It stands for myasthenia gravis, myocarditis, and myositis. And it's a potentially fatal condition, increasingly seen in patients on ICIs, especially those receiving PD-1 inhibitors. The challenge is that not all 3 features of triple M may present at the same time, making it even harder to diagnose.
So what should we be watching for to catch this early?
You'll want to be vigilant for the classic fatigable muscle weakness of myasthenia gravis, especially in the eyelids, eye movements, facial muscles, and those involved, in swallowing and limb movement. For myocarditis, look for elevated troponin levels, abnormal heart rhythms, and even signs of heart failure. With myositis, muscle pain, weakness, and elevated creatine kinase levels are key indicators.
Given the potential severity you mentioned, what kind of diagnostic workup is recommended when triple M syndrome is suspected?
Checking acetylcholine receptor antibodies is a good starting point, though keep in mind they might be negative initially and turn positive later. Troponin levels are crucial to assess for myocarditis, and creatine kinase will point towards myositis.
Would electrophysiological studies be helpful here as well?
They can be, particularly repetitive nerve stimulation and single-fiber EMG, to further evaluate for myasthenia gravis. However, none of these tests are foolproof, and clinical judgment remains essential, especially given the high mortality rate associated with triple M, 37%, according to recent data.
That's a sobering statistic. It sounds like a coordinated effort across multiple specialties is critical in managing these patients.
It absolutely is. Neurology, cardiology, oncology, and often intensive care need to work together to optimize patient outcomes.
Now, shifting gears a bit, I know triple M syndrome isn't the only way these ICIs can impact the nervous system, particularly the peripheral nerves. Can you tell us a bit more about that?
Of course. The most common peripheral nerve complication you'll encounter is ICI neuritis.
And how does this typically present in our patients?
It usually develops gradually over a few weeks with symmetrical, non-length dependent neuropathy.
That sounds very similar to Guillain-Barré syndrome or even CIDP. How can we distinguish ICI neuritis from these other conditions?
While there are similarities, there are also key distinctions that can help guide diagnosis and management. For example, GBS tends to reach its peak severity within 4 weeks, whereas ICI neuritis often progresses beyond that time frame. And unlike CIDP, which is primarily demyelinating, ICI neuritis often has axonal features, on neurophysiological testing.
So if we see reduced nerve amplitudes, but relatively normal conduction velocities, that's more suggestive of ICI neuritis
Yeah.
than a primarily demyelinating process like CIDP.
Precisely. A nerve biopsy, if performed, would show axonal depletion and widespread inflammatory infiltrate, which is distinct from the patterns seen in GBS and CIDP.
Since you brought up treatment, what's the first line for ICI neuritis?
Just like with many of these ICI-related complications, immunosuppression is key, with corticosteroids being the mainstay of treatment.
And I imagine there are specific dosing recommendations based on the severity.
You're right. We typically start with high dose, oral prednisolone around 1 milligram per kilogram per day for 4 to 6 weeks, followed by a slow taper.
Are there cases where intravenous methylprednisolone might be warranted?
Yes, in more severe cases. Where there's significant functional impairment, we might consider starting with intravenous methylprednisolone. Now, here's a crucial point. That highlights the distinct mechanisms at play. Unlike GBS, which often responds well, to intravenous immunoglobulin, ICI neuritis generally shows a much better response to corticosteroids. This underscores the central role of T-cell activation in ICI neuritis.
So for our listeners, the key takeaway is if you suspect ICI neuritis, corticosteroids are your go-to, not IVIG. What happens if a patient starts to worsen when we try to wean them off steroids?
That's a common scenario, unfortunately. In those cases, we might consider adding a steroid-sparing agent, like mycophenolate mofetil. Of course, any decision regarding immunosuppression should involve close consultation with the oncologist to balance the benefits of managing the neurological complication with potential impact on cancer recurrence risk.
Collaboration is key. While we focus on ICI neuritis, are there any other peripheral nerve complications that we should have on our radar?
There are a few, less common but still important ones to be aware of, including mononeuritis multiplex, dorsal root ganglionopathy, and sensory ganglionopathy. These conditions can be particularly challenging because they often show a less robust response to corticosteroids, requiring a more individualized approach.
Interesting. Is there another one of these less common syndromes you could walk us through?
Absolutely. Let's talk about ICI vestibulitis.
Okay, ICI vestibulitis, what is that?
It's a unique and debilitating syndrome of subacute bilateral vestibular failure. These patients present with severe unsteadiness and oscillopsia, which is the illusion that objects are jumping or jiggling.
I imagine that can be quite distressing.
Absolutely. This particular condition is incredibly rare outside the context of ICI therapy. And to make it even more challenging, these patients will typically have a normal neurological exam apart from the vestibular dysfunction.
So imaging is normal as well.
Yes, imaging is typically normal. However, the cerebrospinal fluid might show signs of inflammation. Unfortunately, ICI vestibulitis also often shows a poor response to corticosteroids. So vestibular rehabilitation therapy becomes crucial for these patients to regain functional independence.
That's a lot of very important information to keep in mind when evaluating patients on ICIs. So moving on to management in general for these neurological complications.
Well, as we've touched on already, with a few of these conditions, the cornerstone of management for most ICI-induced neurological syndromes is going to be immunosuppression.
And as you've pointed out, this often involves a delicate balancing act.
Indeed. While corticosteroids are usually our first line, we need to carefully consider potential side effects, such as infections, hyperglycemia, mood changes, osteoporosis, and many others.
So patient education and shared decision-making are absolutely essential.
I couldn't agree more. Having detailed discussions about the potential benefits and risks, the rationale for treatment, and alternative options is crucial. And of course, close monitoring for side effects is equally important.
That makes perfect sense. Now, what about the complex issue of re-challenging a patient with an ICI after they've experienced neurotoxicity?
That's one of the toughest decisions we face in these cases. It requires carefully weighing the risks and benefits, taking into account the severity of the initial neurotoxicity, the patient's response to treatment, and the likelihood of recurrence.
Are there any specific factors that would make us lean away from re-challenge?
Certainly. If the initial episode of neurotoxicity was severe, life-threatening, or resulted in significant and persistent disability, re-challenge might be too risky. Similarly, if the syndrome proved resistant to corticosteroids, we would be very cautious about re-exposure to the ICI.
I imagine the type of cancer and its responsiveness to the ICI would also factor into the equation.
Absolutely. If the patient has an aggressive cancer, that responded very well to ICI therapy, then the benefits of re-challenge might outweigh the risks. However, even in those scenarios, Rechallenge should only be considered after thorough discussion with the patient, obtaining informed consent, and with extremely close monitoring for any signs of recurrent neurotoxicity.
This highlights the importance of a strong collaborative relationship between neurologists and oncologists in these cases.
Absolutely. Open communication and shared decision-making are essential to ensure the best possible outcomes. For these complex patients, we need to work together to carefully balance the need for cancer treatment
Yeah,
with the potential neurological risks.
it's truly fascinating how rapidly our understanding of ICI neurotoxicity has evolved.
It's a relatively new field, and we're constantly learning more about the diverse ways these drugs can affect the nervous system. It's really a testament to the power of collaborative research and knowledge sharing.
And speaking of knowledge sharing, you mentioned a valuable resource earlier, the National ICI Neurotoxicity Multidisciplinary Advice Service. Can you tell us a bit more about what they offer?
Of course, this is a UK-based national service that provides multidisciplinary advice on diagnosing and managing ICI neurotoxicity. Their team consists of experts from neurology, oncology, neuroradiology, cardio-oncology, and rheumatology, all ready to provide specialized guidance on these challenging cases.
So clinicians can actually refer complex cases to them or simply seek guidance on management strategy.
Exactly. They're a phenomenal resource for anyone struggling with diagnostic uncertainty or tricky management decisions. It's a great example of how collaboration can help us navigate the complexities of this evolving field and provide the best possible care for our patients.
This deep dive has given us a lot to think about. As neurologists, we have a crucial role to play in recognizing, diagnosing, and managing these potentially devastating neurological complications associated with ICIs. Our expertise is essential to ensure that these patients receive the best possible care, carefully balancing the benefits of cancer treatment with the preservation of their neurological health.
I completely agree. Vigilance, a thorough understanding of these various ICI-induced syndromes, and a collaborative approach are essential to navigating this landscape.
We'll be back shortly with more on the diagnosis and management of neurological complications from ICIs.
Let's delve a bit deeper into the practical aspects of diagnosing these ICI-related neurological complications. What steps can neurologists take to make sure they're on the right track?
Well, first and foremost, a thorough clinical history is paramount. We need to understand the timeline of events. When did the neurological symptoms start? In relation to the initiation of ICI therapy, what type of ICI are they on? What's the dosage? And how long have they been receiving it? All these details are important.
It's also crucial to distinguish between symptoms that develop quickly versus those that emerge more gradually. For instance, myasthenia gravis and myocarditis often manifest within a few weeks of starting ICI treatment.
Whereas complications, like neuritis and myositis, typically develop over a longer period.
Exactly. And, of course, a comprehensive neurological examination is crucial. We need to pay close attention to patterns of weakness, sensory abnormalities, cranial nerve involvement, and reflexes.
And we can't forget about autonomic dysfunction, which can be a feature of some of these ICI-induced syndromes.
That's a great point. It's always important to assess for orthostatic hypotension, bowel and bladder dysfunction, and other signs of autonomic involvement.
So let's say we've taken a detailed history, performed a thorough neurological exam, and we have a strong suspicion of ICI neurotoxicity. What investigations are most helpful in confirming the diagnosis and ruling out other possibilities?
Blood tests are a good starting point. Checking for inflammatory markers like CRP and ESR is helpful, as well as creatine kinase, which can be elevated in myositis.
And we already discussed the importance of checking troponin levels when myocarditis is suspected.
Yes, and acetylcholine receptor antibodies for myasthenia gravis, though remember that a negative result doesn't completely rule it out.
Would a lumbar puncture be helpful in these cases?
It can be. If we're concerned about central nervous system involvement, a lumbar puncture can help us assess for inflammatory changes in the cerebrospinal fluid.
What kind of findings in the CSF would raise our suspicion for ICI neurotoxicity?
Things like elevated protein levels, pleocytosis, which means an increased number of white blood cells, or the presence of oligoclonal bands, can all suggest an immune-mediated process.
And what about electrophysiological studies? When would we consider ordering those?
Nerve conduction studies and electromyography are essential when we suspect peripheral nerve involvement. They can help us differentiate between axonal and demyelinating neuropathies, which can guide treatment decisions.
Are there cases where a nerve biopsy might be warranted?
Yes, though less common. A nerve biopsy might be necessary in atypical presentations or when other investigations Having given us a clear answer, it can help confirm the diagnosis and give us more information about the underlying pathology.
Now let's talk a bit more about managing the immunosuppression. That's often the cornerstone of treating these ICI-related neurological complications.
As we've mentioned, corticosteroids are usually our first line of defense. The specific dosage and duration of treatment will depend on the severity of the neurotoxicity and how the individual patient responds.
And of course, we need to closely monitor for those potential side effects you mentioned earlier and adjust the treatment plan accordingly.
Absolutely. If the patient isn't responding to corticosteroids, or if prolonged high-dose steroids are contraindicated, we might consider adding a steroid-sparing agent, like mycophenolate mofetil or azathioprine.
What about intravenous immunoglobulin or plasma exchange? Are those ever used in these cases?
They can be, particularly for syndromes, with a strong humoral component, like myasthenia gravis. But their effectiveness in treating other ICI-induced syndromes, like neuritis, is less clear.
So we really need to carefully consider the risks and benefits of each treatment option based on the specific clinical scenario and the individual patient's presentation.
Exactly. And throughout the management process, maintaining open communication with the oncologist is absolutely essential.
You need to be in sync regarding the potential impact of immunosuppression on cancer treatment and make joint decisions about whether to continue or discontinue ICI therapy.
And that brings us back to that particularly challenging decision of whether to re-challenge with ICIs. After a patient has experienced neurotoxicity,
What are the key factors we should consider when wrestling with that decision?
the severity of the initial neurotoxicity is a top priority. If it was life-threatening or resulted in significant disability, then the risks of re-challenge are likely to outweigh the benefits.
And I imagine the type of cancer and how well it responded to the ICI initially are also key factors.
Absolutely. If it's an aggressive cancer, that showed a remarkable response to ICI therapy, then re-challenge might be a reasonable consideration. But it has to be approached with extreme caution.
What about the patient's overall health and their willingness to accept the risks of re-challenge?
Those are crucial factors as well. This is where shared decision-making becomes so important. The patient, the neurologist, and the oncologist need to have open and honest conversations about the potential risks and benefits, and the ultimate decision should reflect a shared understanding and agreement.
It's exciting to see how much progress has been made in understanding and managing these ICI-related neurological complications. What does the future hold in this field?
The research is moving at an incredible pace, which is really promising. We're learning more about the underlying mechanisms of ICI neurotoxicity, and that's paving the way for the development of more targeted and effective therapies.
Can you give us an example of what these new therapies might look like?
There's a growing interest in the role of specific immune cells and inflammatory pathways in driving these complications. That knowledge could lead to the development of biomarkers that can help us predict which patients are at higher risk of developing neurotoxicity.
So it could potentially intervene earlier
Ugh.
or even take prophylactic measures in those high-risk patients.
That's the hope. And there's also a lot of research focused on developing novel therapies, such as monoclonal antibodies that can target specific inflammatory mediators.
That's fascinating. These new therapies could potentially reduce the severity of these complications and improve outcomes for our patients.
Exactly. Another exciting area is the use of artificial intelligence in predicting and managing ICI neurotoxicity.
How would AI be applied in this setting?
AI algorithms can analyze vast amounts of data, looking for patterns that might not be obvious to human clinicians.
So AI could help us personalize treatment strategies, maximizing efficacy while minimizing the risk of these neurological side effects.
Precisely. The future of ICI neurotoxicity management is bright, filled with the promise of new discoveries and innovative therapies.
It's an exciting time to be involved in this field.
It truly is. As neurologists, we have a responsibility to stay at the forefront of this evolving field.
By embracing new knowledge, collaborating with our colleagues in oncology and other specialties, we can ensure that our patients receive the best possible care, balancing the need for cancer treatment with the preservation of their neurological health.
Well said. ICI neurotoxicity is a complex and rapidly evolving field, and a multidisciplinary approach is essential. We need to stay informed about the latest research and treatment advances to effectively navigate the challenges and provide optimal care for our patients.
This deep dive has given us a comprehensive overview of the neurological complications of ICIs, from the mechanisms and clinical presentations to the diagnostic challenges and the evolving management strategies. But this is just the beginning of the conversation.
Absolutely. The field is constantly evolving, so continuous learning and engagement with the latest research are essential.
We encourage all our listeners to explore the full article by Carr and colleagues. It's a valuable resource for any neurologist caring for patients receiving ICI therapy, and will continue to bring you the latest insights on this topic and other fascinating areas of neurology in future episodes. In our final segment, we'll explore how you can be proactive in the care of your patients receiving ICI therapy to help minimize the risk of these neurological complications. We've covered a lot of ground on the diagnosis and management of ICI-related neurological complications. But what practical steps can our listeners take to be proactive in the care of their patients receiving ICI therapy?
Early involvement is absolutely key. Don't wait for neurological symptoms to appear before engaging with the oncology team. Neurologists need to be part of the conversation from the very beginning.
So we should be discussing the potential neurological risks of ICIs with both the oncologist and the patient
Right.
before therapy even begins.
Precisely. It's about having those open and honest conversations about the potential benefits and risks, however rare those risks might be. Informed consent is paramount.
What are the key things we should educate our patients about?
Make sure they understand what signs and symptoms to watch out for. Red flags like sudden weakness, changes in sensation, vision problems, difficulty breathing. These warrant immediate attention. Early detection and intervention can make a world of difference.
That makes sense. And what about monitoring? What's a reasonable approach?
Establishing a neurological baseline before ICI therapy is essential. A thorough exam that documents any pre-existing neurological issues can help us differentiate those from potential ICI-related complications down the line.
And that we would follow up with neurological exams
Yeah.
at regular intervals, even if the patient is feeling fine.
Exactly. The frequency will depend on the individual patient's risk factors and the specific ICI they're receiving.
Yeah.
But checking in every few cycles of treatment is a reasonable approach. And of course, if any new symptoms arise, we shouldn't hesitate to order targeted investigations.
This all points back to that essential collaboration with the oncology team that you've emphasized throughout our conversation.
Absolutely. Open communication, sharing information, and joint decision-making are crucial to navigate these complex cases effectively. And let's not forget the valuable resources available to us, like the National ICI Neurotoxicity MDT. They can provide expert guidance and support, especially when we're faced with a challenging case or uncertainty about the best course of action.
It's truly remarkable how far we've come in our understanding of ICI neurotoxicity in such a short time. But as you've highlighted, it's a rapidly evolving field.
It certainly is. Continuous learning is essential for any neurologist involved in the care of patients receiving ICI therapy. Stay engaged with the latest research, attend conferences, and don't hesitate to reach out to experts when you need guidance.
This deep dive has provided a focused look at the neurological complications of ICIs. The key takeaway for our listeners is this. As neurologists, we have a vital role to play in recognizing and managing these rare but potentially devastating side effects. Our expertise is essential in ensuring that patients receive comprehensive and compassionate care, striking that delicate balance between the benefits of cancer treatment and preserving their neurological health.
For those who want to delve deeper into this topic, I highly recommend checking out the full article by Carr and colleagues. It's an excellent resource filled with practical guidance.
And remember, the field of ICI neurotoxicity is constantly advancing. New discoveries and therapies are on the horizon, offering hope for even better outcomes for our patients in the future. Stay tuned for next week's deep dive, where we'll explore another fascinating topic in neurology. Until then, keep learning and keep pushing the boundaries of neurological knowledge.